Okay, well, I will now kind of shift us here and let me formally welcome everybody. Welcome to our Duke educational webinar series. Today, we are absolutely delighted and proud to have Dr. Pawel Jastreboff, who is someone who many, if not most or all of you, have heard of, and I will do a formal introduction in just a moment. But we're going to be talking today about how the term misophonia came about, and Dr. Jastreboff, what he thinks about what misophonia is and how to help people with misophonia. We'll have a lively, interesting discussion. So thank you everybody for being here. I'm going to just take a couple of minutes before we get started and orient you all. If you're new to this webinar series, again, welcome. My name is Zach Rosenthal. I'm a psychologist and I lead the Duke Center for Misophonia and Emotion Regulation. We are a group here at Duke Health in the Department of Psychiatry and Behavioral Sciences. We have an overarching mission as a center to be international leaders in the advancement of research, education, and clinical services for people with misophonia. And we're really excited to do this work. We do a lot of work across all three of these areas, and it is incredibly rewarding and humbling and a privilege to do this work. We do this work at Duke, but we also do this work across the world. We have many collaborators who we appreciate having the opportunity to work with. Misophonia is a global thing. It's not an American thing. It's not a thing in any one socioeconomic status or country or culture or age group. This is a newly named 25 years ago or so, if you consider that newly named disorder. And it's recently begun getting quite a bit of scientific research behind it in, I would say, arguably the last 7 or 8 years. But most certainly, this is not a new phenomenon. It's just newly studied, and it's newly studied around the world. So this is an exciting time to be a scientist and clinician, learning how to help people who have been suffering for a long, long, long time, and now are hopefully beginning to experience a bit more hope. So as we get ready to get ourselves started, I want to thank Dr. Jastreboff. Thank you for being here, Pavel. It's really quite an honor, and I really appreciate you and Margaret and the work you all have done. Thank you for this today. I also want to thank the Brown family, who provides funding for our outreach and education, for everything we do for SEMR outreach. Thank you to Eliza and Hal and family. We also want to thank all of the people who provide funding to our work that's quite generous, whether it's a small amount or a larger amount or a very large amount. We really appreciate everything everyone gives. And I say this in all of these webinars, it's really true. We could not be doing the work we're doing. We never would have been able to start doing the work we're doing without funding support. And as you may or may not know, here in the US, the government does not really fund research very easily. And there's quite a bit of difficulty getting large amounts of funding for something like misophonia. So we really are very, very, very grateful. We couldn't exist without you all. So thank you. Thank you for that. And thank you to Duke School of Medicine and our department leadership for supporting our center. We really appreciate the support they provide, and it allows us to do this work to support all of you. So again, thank you to everybody. And last, our team, the Duke SEMR team, is a terrific team of people, and I just am beside myself with luck and privilege every day to work with these people. So thank you each of you for everything you do. Friendly reminders for today. This is a misophonia education series, so we really appreciate and hope that folks will keep your microphone and camera off during the presentation portion of the webinar to respect other people potentially being distracted or triggered. Um, Please be mindful of others and avoid any actions if you are on camera or if you are using the microphone. Just really be thoughtful, be mindful about misophonia and not intentionally or unintentionally triggering people. And everybody has different triggers. We know this about misophonia. So really just try to be very, very thoughtful. And we do as well. Dr. Jastreboff will be mindful. I know he always is. I will be mindful as well. If anybody ends up feeling triggered inadvertently, we apologize in advance. And the last thing we want to remind folks here is we will have the Zoom chat open and encourage you to use the Zoom chat during the presentation to ask questions, to make comments. At the end of Dr. Jastreboff's presentation, we will go through and ask some questions from that chat to him directly, and we'll have a bit of a conversation together about your questions. In the Zoom chat, we ask very respectfully that there are no promotions of any materials, nobody talking about books they would like to sell that they've written, and nobody talking about things that they have sold or that they are selling that they would like others to buy. Please respect this is a free event with no intention to have anybody trying to sell goods or services directly. Thank you for that. We appreciate that. And last here is you can with us at any point connect with us. We are, thanks to the great work of Grace Heppis and our team, we are very active in social media. If you're an Instagram person, please do follow us at Duke Center for Misophonia. You can follow us really in any of these links here or just go to our website. We're not selling anything here. We're really just trying to give information away that is science-based, evidence-based, practical, reasonable. We don't promise the moon. We don't promise cures. We don't promise everything. We really try to be reasonable and practical, yet also inspiring and provide hope to people as the science advances. So I will now stop sharing, and I'm going to now introduce Dr. Jastreboff. Dr. Jastreboff is really just as many of you know, he's literally the person, he and his wife coined the term misophonia. They together are pioneers in this field. Dr. Jastreboff is a globally recognized pioneer more broadly in the science of sound tolerance disorders, which includes misophonia, but very importantly, as he will, I'm sure, allude to, also includes other disorders. Tinnitus, as one really strong example. Dr. Jastreboff is a real pioneer and leader in the field of tinnitus and misophonia. He is a professor emeritus at Emory University School of Medicine and visiting scholar at University College London. And again, his work has been foundational in creating the ability for all of us to learn and do science and grow and hopefully improve and help people who have misophonia. So once again, everybody, please welcome Dr. Jastreboff.
Great. Oh, yes, I'm seeing you. Well, I would like to thank Zach for this invitation, for such a nice introduction. Um, Indeed, story with misophonia started 25 years ago, or less, and started from the fact that being neuroscientist without clinical education, it happened that I created something which is known as a tinnitus retraining therapy, which included as well treatment for hyperacusis. And I created this in the 80s when I was at Yale University. And I was trying to find out if it really works. It was based on the neurophysiological model of tinnitus and hyperacusis. So in 1990, I managed to open first tinnitus and hyperacusis center at University of Maryland at Baltimore. And during 90s, I've seen personally over 800 patients. And majority of those patients had not only tinnitus, but as well what at this time we're calling hyperacusis. We have a problem with a tolerance to sound. And everything was fine. The effectiveness of the treatments was very high. But at the end of 90s, I got overwhelmed by patient and I have obligation, grant writing, and so on and so forth. So Margaret, my wife and collaborator, who from basic education is pharmacologist, molecular biologist in the anti-cancer medication, joined me and start seeing patients. And she's sharing with me feature that we are treating what patients are saying very seriously. We are listening, hearing, and even if we disagree with patient thoughts of what is happening, the problems, we definitely are taking this into account. And Margaret noticed there's a group of patients, actually like a two-thirds of the patient who express decreased sound tolerance, um, who do not really fit the definition of misophonia. They were sensitive to some specific for them, for given patient, sounds and can tolerate much louder sound, music or so. And this group of patients really did not fit the definition of misophonia, and misophonia was purely related to the physical parameters, acoustical parameters of the sound. Initially, I was skeptical, I have to admit, but Margaret showed me patient after patient, and I decide that it's really something with. We have a heavy discussion, and we decide that it's a new, we're observing phenomenon which probably existed from beginning of a human race, but was not named or recognized formally. And as you know, if in medicine something has no name, it doesn't exist. So we decide that we need to name this, define this, and try to find the treatment, obviously. Name. Since the patient just responding to sound in negative manner, we wanted to find something which would be indicating both component of a sound, although some of them were acting to visual stimuli too, and something which indicates something is bad. So I asked my friend from Cambridge University, Cambridge, England, who was expert of Greek and Latin literature, to send me a list of prefix, which I can connect to the word phonia, which is voice, sound, to indicate something bad. And he sent me a nice list of 30 or so prefixes, and we just look at this. Majority of them they were very good, but was looking for something is short, easy to remember, and still being reasonably nasty in describing things. And I pick up the word miso, which in Greek means hate. But from the very the beginning, and we were making it clear, misophonia does not mean hate of sound. For me, it will be absurd. It's the same as saying that chromatography is painting by color, which literally means, if you translate it literally. Unfortunately, some people pick it up and start claiming that characteristic feature of misophonia is hate, which is absolutely definitely not true. Hate exists in some patients, but not very frequently. It's rather one of the less frequent feature. So we start. And once we have it, I was thinking from point of view of neuroscience and existing model of tinnitus and hyperacusis. I expanded this model to include misophonia, and from this result, I got an idea of treatment, which was different than treatment for hyperacusis. Uh, Treatment, I'm sorry, something is happening on the screen. Okay. Uh, Treatment for hyperacusis is not working for misophonia. And It's different, it's more complex. In addition to the different counseling, which I was using for tinnitus and for hyperacusis, uh, involves four different levels or categories of protocols. And the protocol level one, I published in 2002 in the paper which introduced in peer-reviewed literature misophonia to the world. So this was how all of it started. And well, I'm open to any questions which might be of interest to you.
So here, if anyone has questions about this first part of the presentation, about how the term misophonia was coined, please feel free to ask those questions in the Zoom chat. Or if you like, you can unmute and ask directly.
Well, maybe in the meantime, when people are thinking and writing, I just briefly outline what what's the treatment for misophonia, how it works, and which kind of a result we are expecting and we are getting. Uh, Treatment of misophonia, it's
Actually,
the same.
Pavel, Dr.
Yes,
Jastreboff, if you would, just before you go down that road, because that will be where we stay, there is a good question in the chat. I'd like to interject and just kind of politely stop you at
sure.
that moment because I
Absolutely.
know where it will go, and it will be the rest of our time.
Please do.
Is a really good question here that I've actually wondered myself what you think about this. Someone asks, what do you think would be a more accurate term rather than misophonia?
What I think that, well, first of all, I'm not treating misophonia to translate directly. The same as for many things I mentioned this chromatography. Nobody thinks that chromatography is, the drawing by colors, or photography is the drawing by light. So I'm not sure if this apply to the type of a disorder which involves sound as well. But what I'm proposing, what I'm observing in some patients, the similar reaction to other sensory modalities, not only to the sound. So the weakest part of this is phonia, not miso. And you can have a reaction to the smell, touch, visual, of course, visuals are quite common. People can see source of a sound without hearing sound and react to this, which is well described. Um, and I just check with some of a Greek patient who is well versed in the classic Greek, number of Greek words for different sensory modality. And I wrote it in one of the very recent papers, which is, I think, now in press. But I think it would be nice to find something which should be covering all the category of sensory disorders, which involves not only sound. For sound, I think that misophonia is fine. But it's not only the only disorder from this general category.
Okay, thank you. I'm looking through here. Um, Another question similar before we move on. Someone asks, if it doesn't mean hate of sound, what does it mean to you?
Any kind of negative reactions to sound, which do not depend on the physical characteristic of the sound, but patient parts experience involve learning, typically depends on who is making this and in which surrounding sound is exposed, uh, which is contrary to, again, hyperacusis, which depends on the characteristic of a sound its spectrum. In case of misophonia, meaning is crucial. So example which I like to use during teaching and with patients, but if imagine that somebody hates sound of my voice, when I'm speaking, sound of mother, or sound my voice. So if you record this and do fast Fourier transform, which provide a possibility of reconstructing my voice from the point of a spectrum, identical levels, all frequencies, but losing time components. That means the speech becomes noise. It sounds like a noise. It's exactly the same energy, the same spectrum, but no meaning. In case of a hyperacusis, patient will be reacting identically to my voice and noise made of my noise. In case of misophonic patient can react to my voice, but will not react to noise which is meaningless. The same to some extent in between, you have a possibility, and there's some study done now, understand this, but you are recording voice of patient for some of the speaking, which is misophonic trigger to patient, and then associating this with a different person. So it's in the different person is speaking the voice of a patient with a person who is normally creating problem. And then the reaction are weaker or might disappear. It's an issue that we are reacting to complex stimulus, not only simply to sound. In the case of misophonia, concept of complex condition reflexes and complex condition stimuli is absolutely crucial, in my opinion, to understand misophonia and be able to effectively treat this. This actually, I believe, explains majority of observation and puzzles of misophonia.
All right. Thank you for that. And I'm going to press unpause, so to speak, and let you go back to treatment. There are lots of questions in here about treatment and cure. So please proceed, if you will, with sharing a bit about how your understanding of misophonia has translated into the therapies you've developed and what you think is helpful for people, and maybe how they can get help.
Thinking about misophonia, when I try to create some uh, potential, find some potential mechanism. But I would like to point out, first of all, that when we are introducing misophonia, we created double level, double type definition. One definition, which was based on the behavioral observation of a patient, is misophonia, as I was telling you, reaction to a specific sound, specific to given patient, blah, 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 without any mentioning or any assumption regarding neurophysiological or physiological or psychological mechanisms of misophonia. And I believe that this definition is very important to recognize, although those definition is not allowing you to propose treatment for misophonia. It allows for defining if somebody has a misophonia or not, or to which extent even. But when I was starting over potential mechanisms, I noticed that reaction to misophonic triggers are basically identical to reaction of hyperacusis patient to bothersome sound. And it's a very lot of similarities. We look deeper into this, into systems which are potentially carrying on misophonic signals in the brain, as in case of a tinnitus. The difference is that in case of a tinnitus, bothersome signal is generated within auditory pathway. In case of misophonia, it's a signal which is happening, is created in the auditory pathways, but evoked by external sounds. And in case of misophonia, pattern recognition is crucial, and of this complex conditioning stimuli and so on. So this caused that I start thinking that, well, the concept which I propose in the neurophysiological model of tinnitus and hyperacusis, that means that to understand and treat those problems, we need to involve all brain and not only peripheral auditory system, which was tendency in 80s when I entered 1983 field of tinnitus. So if it is the case, for me, misophonia was result of creating inappropriate function connection between auditory system and other system in the brain, particular emotional system, limbic system, and system which is controlling body function, autonomic nervous system. And it's a very well recognized that overactivation part of this autonomic system, formerly known as the sympathetic part of autonomic nervous system, creates annoyance, panic, anxiety, and triggers this survival reflexes of any kind. So, from a point of reaction, patient with tinnitus, hyperacusis, misophonia show similar, or in case of a hyperacusis misophonia, basically the same reaction. So for me, it indicates that we need to do something, retrain subconscious brain, which is deciding which stimuli are important, which are not important, which can be ignored, habituated, which has to happen at the subconscious level by definition. So in this case, my idea was that what is happening? Inappropriate connection, which again can be created by using concept of condition reflexes, are happening, and subconscious brain is making incorrect decision that given sound is bad, and once this is done, it's difficult to correct. So my method was based on what I learned about reflexes, about subconscious brain, and I'm not ignoring conscious thinking part of the brain. Definitely not. And counseling is aimed to large extent into teaching patient mechanisms, potential mechanisms of misophonia, and as well potential mechanisms which we can use to break this connection, function connection between auditory system and emotional system. And we know from neuroscience, from neurophysiology, existence of this connection. We can talk about specific structure. It's medial geniculate body and lateral ventral nucleus of amygdala. Amygdala, one of the main structure of our emotional system. And trying through, with the help of sound and sound therapy, and I mentioned this 4 different type of protocols, retrain this connection. So the final outcome is, well, first of all, people start reacting weaker to misophonic triggers and hopefully stop to react at all. We published 83% of success rate in treating misophonia, as well as hyperacusis and tinnitus as well above 80. And in many cases, we're observing total disappearance reaction to the sound which previously were misophonic triggers, like misophonia never existing. I am observing some patient for, 25 years. The first patient, which was fully treated for misophonia, was from 1990, and he's still fine. And he was in house arrest, was unable to go out of the house for 10 years. And I'm definitely positively not claiming that whatever I am proposing as part of TRT is helping everybody. I have a patient on whom I'm failing totally. There's no improvement at all. But for this over 80% of the patient, we are seeing clinically significant improvement. That means we have an improvement, substantial improvement in their life, what can do, what not do. And many misophonic triggers disappear at all. Some might still remain, but it's a substantial improvement. And I believe that we're using more stringent criteria for defining clinical success the majority of other researchers in the field of tinnitus and misophonia. And definitely we have a number of cases when misophonia is totally gone. We haven't seen remission yet. You never know. And I have probably close to 2,000 patients, which I've seen personally. And I'm following patient for a long time, even after the treatment, just from time to time checking. And many patients just because they like what happened with them are sending me emails, holidays greeting and things like that. So it's defined that how you define the word cure and which kind of a definition you use, what's your opinion. But I think that for some people, and it's a substantial proportion of our patient, we are achieving cure in the meaning that the triggers which previously create problem are totally gone, and they have no problem which are related with decreased sound tolerance in their life. I don't know if I answer your questions sufficient detail. Going into the detail how we are doing this, yeah, we had a 5 days intensive course for professional, 8 hours, 7 or 8 hours a day, in which we're explaining all of this number of lectures on misophonia and treating misophonia, because misophonia, honestly, is more difficult to treat than tinnitus or hyperacusis. Hyperacusis, pure hyperacusis is easy. It's just, few months and it's possible to totally remove it in majority of the cases. Mesotinnitus is reasonable, is just its time, and if patients are following instruction, are doing fine. In case of misophonia, as well, it's possible to have basically the same success rate, but it's much more complex and involves more involvement from providers. You need to not only understand patient, that's my opinion, on just cognitive level, intellectual level, but it's necessary to feel, to try to feel the patient feeling and have empathy. It's a very important, I believe, part of why uh, I'm successful with patients.
Dr. Jastreboff,
Uh,
can I interject? There's some questions people have, and I think it would be helpful if you maybe take a couple of minutes and can you describe, and I know it's hard to do in a couple of minutes, but maybe you could try to describe what is the treatment that you are describing? What is the treatment? What would the experience be like for patients? And ultimately, where could they get help from that treatment if they were interested?
right. Uh, Treatment consists in several components. First of all, we have a very detailed, it's typically an hour, about an hour or so, structured interview when we're checking number of things, asking number of questions to a patient, and listening to any other things which patient associate with the problems. And this plus audiological evaluation, particularly the finding so-called loudness discomfort level and audiogram, is very helpful. Allows for proposing version of a treatment. Each patient is different. And each patient needs to be treated individually, but there are certain common things. Then we have a intensive counseling teaching session is about 2 hours, of which mainly provides information about mechanisms of misophonia, and as well mechanism of the brain function, how brain is working, and we can this mechanism which we can use to control misophonia and cause the brain stop reacting to this sound, to misophonic triggers. And as I told you, it's 2 hours extensive counseling. And to some extent, simplifying it a lot, is we are trying to make problem of misophonia boring. That means it's bad, it can hurt a lot, but it's nothing else to understand about misophonia for patient. Patient understand what is this, why, and what we are trying to do to remove this.
Can you
Um,
talk some about beyond the counseling part, what the treatment you provide entails that helps change that nature of the response in the brain? What would a patient expect that would look like for them if they were receiving that treatment? Not the counseling part, but the
Yes, yes. And second part is using methods basically from retraining condition reflexes, different methods, passive and active retraining method, and so on. And from a point of a patient, it involves, for example, protocol level one. It's listening to favorite music at the perfect level of a listening pleasure for 15 minutes, 10 minutes, focusing attention on this pleasant sound. We're trying to create positive association of a sound, any sound, with feeling well, feeling happier, and this, through so-called generalization principle, gradually expand to other sounds. This is protocol level one. It has another twist, allowing the patient to listen to louder and louder sound as a normal. But this is the heart of this. And I wasn't expecting that this approach would be so successful, as I told you. I published it as a book in 2002, while using this from very beginning of a treatment misophonia, and it turned out to be very effective. In some patients, the mild misophonia, it wasn't basically nearly all which need to be done. But we're getting to the more complex situation when patient is exposed to the misophonic triggers, but with a different level of a control of environment. For example, going to, it will be protocol free, going to movie theater, but going only for most favorite movie. So we're trying to have a situation patient can hear misophonic triggers, but in the same time is pretty happy, has a very strong positive setting of emotional system because likes very much a given movie. But going for not the average movie is forbidden, so to speak. Well,
would
not
you
recommended.
would you
And
describe?
finally, and finally,
Yeah.
the final protocol level four, most complex, and which requires from patient to understand what's going on, and patient actually is shaping this protocol, and I'm just teaching rules, is a creating situation where using multisensory complex conditioning stimulus. What does it mean in the practical term? You have a misophonic triggers, but in the same time, let's imagine simply somebody is reacting too strongly to the reaction to eating and cannot eat together with family. And for many patients, it's a significant problem. So telling patient as exercise, not every day, but exercise, few times a week. Have a dinner uh, during which you are playing most favorite music, and you are teaching the level. It says as well how to set the level of the sound. Most favorite music or most favorite sound, but typically it's the music. In the same time, inducing other positive things can be, favorite food, uh, proverbial dinner at the candles. And what we're trying to do through a sound, we're decreasing strength of misophonic triggers. And this is actually a crucial part of dealing in case of tinnitus and hyperacusis. And the brain is not perceiving sound at the absolute physical level, but there's a difference in the background. So when we have a misophonic figure is the same level, right? But by increasing background sound, we're decreasing this difference, and brain reacts to this difference. And second thing is that complex conditioning stimuli allows, we create situation that reaction to complex stimulus, and we can do it very nicely in animals and humans, is different, that can be different from the reaction to individual components. In case of animal, if you take a rat and you put in the cage and play the sound and give at the end mild electrical shock, rat will be frightened, will be, defecating and so on and so forth because it's not nice. But if you have exactly the same situation, the same this sound, and now you are playing, let's say, music, different sound, and end of this you are giving piece of a cheese, rat learn very quickly that just this sound without anything means danger, but sound with other sounds, more complex, indicates something nice to happening. And we can do it the same by simply giving shock rats in the cage and putting rats on the floor and giving rats exactly the same sound, but on the floor, not in the cage, and giving cheese, and rats will learn very well. Shock in cage, sound and shock in cage is bad. On the floor, it's very nice. And we are using this principle, how our brain working, by purposefully creating this complex conditioning stimuli consisting of several components. And then, in the next stage, very gradually, we're decreasing this positive components of conditioning stimuli. And what is happening, the patient initially reacting weaker and then keep this weaker reaction up to the point it disappear to the misophonic triggers. It can happen pretty fast. Sometimes it's longer, taking longer time, but there are cases that it's really pretty fast. And we're observing clear improvement on average within 3 months. More improvement 6 months, more improvement 9 months, and so on. And I insist that patients are under the treatment control for at least 9 months, even while improving wonderfully earlier, to prevent relapse. And as I mentioned, I am not observing relapse.
Question for you.
Normal treatment is 9 to 18 months,
Que-
more or less.
Question for you, Dr. Jastreboff. Briefly, can you point the audience to where they might find a provider who has training in the treatment approach you're describing that they might reach out to?
Well, excellent question. Um, for our courses and this genre, we have a 54th TRT course with 5 days intensive course. We're teaching about misophonia, and people after this course are well prepared to start working with tinnitus, hyperacousis, and misophonia. I'm not controlling those people, and you have a good student, a bad student in the audience, and you do not know. But some of those people are doing pretty good job. At this point of the time, I have in contact with only few people. But what I created with Jonathan Hazel many years ago in 90s, so-called research, uh, tinnitus retraining therapy association. There are people who want for our courses, who are exposed to the knowledge and practice for at least half a year, whatever you are doing. And they are signing statement that they are following certain rules, which are teaching them how to treat patient. And they are treating this patient following this rule. They can have a use other treatment as well, or other treatments adjunct, but they are at least following those things. And I have to admit, with my limited resources, I'm basically working alone. I do not have other people helping me in keeping web page and so on. This web page is pretty dreadful, but this page contains a list of members of Tinnitus Research Association. It's a www.tinnitus-pjj.com. PJJ, Paweł Jerzy Jastreboff, my initials. And I decide that since I'm now seeing only very, very single and typical catastrophic cases. I decided that's enough. I should really start to retire. I formally retired in 2016. So what I'm going to do it now, and I hope to do it by the end of the year, to send email to all the people on this list, plus all the people on the recent courses, asking them if they're following the TRT and if they're treating misophonia. So I hope that sometimes in January I'll be able to present modified version of this TRT Association membership list, and then patient can find on this who declares that they are treating misophonia. I cannot tell if it's a
Right.
good or
Right.
bad because I have no control.
Will you send uh, maybe you could type in the address. The someone is asking for the actual. Oh, never mind. Someone, thank you, Samantha. Never mind, Dr. Jastreboff. Someone just typed it in for us. Thank you very much. Um, Thank you for that. That will be helpful. People can check that link, and it sounds like in the new year you should have more updated information for possible people. We have 10 minutes left, so I'm going to ask you a couple of questions and ask you to give very brief answers because we have a lot of great questions from the audience. And so we have to be brief. And you and I both have problems with being brief. We know that together from our conversations. So let's.
But I have additional problem. You don't have an accent. And I know very well from practice that if I try speaking too fast, because I get emotion and this, I cannot understand myself, and there's no way that other people can understand me. So I
Okay,
have to
here,
speak relatively
agree,
slowly.
agree. Here, but
But short,
speak slowly but briefly. Thank you
correct.
for that. Yes. So, a couple of questions, real quick. There are questions about what other treatments might work. So, just if you could say, yes or no, or very briefly, does neurofeedback work? Does hypnotherapy work? Um, what are the other treatments that you think have been shown to work? Does exposure therapy work? So people are asking questions about what are all the other treatments that might work for misophonia, and maybe you have a brief answer for that.
On treatment who might work, and again, depends on the implementation. Cognitive behavioral therapy seems to be on the top. Definitely, exposure therapy can make situation worse. This approach with flooding, like in case of phobias, I'm afraid, it's a disaster for our patient. Hypnosis is not working. Neurofeedback is not working. So I think that at this point of a time, I would be considered that something which is effective is
Someone
TRT
else.
and cognitive behavioral therapy.
Thank you for that. And last one, someone just typed in, what do you think does eye movement and rapid desensitization therapy work for misophonia?
Um, uh, I know about this, I read about this. I haven't seen data which would be sufficiently strong to support this doing that is really effective.
Okay, thank you.
Well, time will show.
Yes, correct. Science will tell us what seems to be helpful and what not. There is a really thoughtful question with multiple parts. I'm going to try to just again ask you to try to answer it as quickly as you think is feasible. The question is, with patients you've worked with, have you noticed whether childhood trauma or abuse often plays a role in how misophonia began, how it started? And the second question is, what do you think about age and misophonia severity? Do people's triggers and severity, does it get worse as they get older?
Let's stand for the last ones I can remember. Uh, in case of a tinnitus, hyperactive misophonia, tinnitus, if it's not treated, is stable. For 40 years can be the same. Hyperacusis, if not treated, tends to get better. Misophonia, if not treated, as basically nearly everybody is getting worse. We have a specific question, our questionnaire. So it was the last question. What was the first one?
First question was, have you observed clinically
Oh, yes, I remember the
abuse
age
in
and so on and
childhood
so
as
forth.
part of a cause of misophonia?
It's I would put it slightly differently. Um, Misophonia, in my opinion, starts with a situation when a sound, presence of a sound, and person is a bad mental, physiological, or physical situation. And this is a component with a requirement which is sufficient for creating this condition reflexes. So misophonia can be created in anybody, absolutely healthy, absolutely normal, by creating such a situation. Um, Definitely trauma in childhood might promote the probability of such a situation happening. But uh, I will not say that it's creating misophonia is worse. Regarding age, children are wonderful for treatment. Favorite group of a patient for Margaret, which Margaret likes, it's a patient with autism.
Mhm.
Really very nice result of this. I have some autistic patient too. Um, but children generally are getting very nicely. And the only problem with children are parents. You need to, counseling has to be oriented toward strongly toward parents. So parents are not interfering with what they think is good for child, which not necessarily is correct. For example, is the issue of accommodation. Accommodation is needed, but should be kept to the bare minimum. Larger accommodation tends to create the worsening actual misophonia. But it's a separate big issue. Aging, well, my patient, the youngest patient is 5 years old. The oldest, I think, is 95. And elderly can do very nicely as well, in spite of everything, providing that they're not on strong psychotropic medication. And one of the requirements which a member of TRTA need to follow is do not promote using of benzodiazepines. Benzodiazepines, in addition to all the addictive properties and so on and so forth, have a nasty feature of decreasing brain plasticity. In the case of my treatment, the same as a CBT treatment, also plastic brain which can learn, can change, is very important.
Okay, okay. Question for you about exposure therapy. This comes up a lot in our questions with families and patients, and in these webinars, this comes up very regularly. And since you're here, let me ask you. You said you don't think exposure therapy will work and it can make things worse. You've described your treatment as a very behavioral therapy, a very behavioral treatment with conditioning principles. Can you explain simply? I know it's got to be quick and that's hard to do, but can you explain simply why exposure therapy might make things worse compared to maybe a counter conditioning or model like your model that uses other learning principles?
Exposure therapy, which involves that the subject is exposed to misophonic trigger repeatedly. And the problem is that if you accept that misophonia really has this condition reflexes, stimulus reaction, if you are repeating stimulus without changing something like by changing stimulus by this complex conditioning stimulants and so forth, by definition, will be making this connection stronger. So exposure therapy by just exposing to misophonic triggers uh, should, and I'm observing this on patients who are coming to me and who went through this, is typically causing worsening of the symptom and not helping. I, it depends, will be probably on how it was applied, what is else happening during this exposure therapy. But from the point of view of what I am seeing in my model, it's worsening because it's enhancing condition reflex by repeating negative stimulus. And if you are doing the training, well, by definition, you make a connection stronger and not weaker. And we want to have this connection disappear, to make
Yes.
it getting weaker and disappear.
Thank you. Thank you for that. I'm going to try to squeeze in two last questions here. And thank you, everybody, for your excellent questions. Apologies in advance to those we couldn't get to today. And my last two questions for you. Interesting question, and again, it's got to be a quick answer for now. But do you think there's some evolutionary advantage associated with misophonia? I've heard this question for many, 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 many years from many people, that perhaps there's some evolutionary advantage or there's some evolutionary component. What do you think?
Yes, the answer is yes, partially, because misophonia is enhancing being over careful in words which is not necessarily friendly to us. It's better to avoid stimuli which indicate danger, even if we are making error in the direction that actually the stimulus is neutral, that ignore it and get hurt or get killed. So from this point of view, misophonia is at making people more careful in evolution from any kind of stimulus, and that you have mistakes, right? You're making mistakes of judging something like a bad is not bad, but again, it's safer to make mistake in this direction but than making mistake as a misophonia is that the sound is fine and actually it indicate snake coming to you.
I completely agree, and it makes really perfect sense. Um, my last question will come to you. It's more of a personal question, and before I ask it, I just will note and thank you for highlighting your experience with your treatment, but also being responsible and ethical in how you described it. Works very well in your experience for many people, but as you said, it does not work all the time for everyone perfectly. And I think that's
Absolutely.
just a very important note for everyone to hear that there really is no single cure for all people all the time. There are treatments that may be helpful, and you've heard Dr. Jastreboff describe his. So thank you for that, Dr. Jastreboff. Quick question. How did you and Margaret get involved? Did one of you have misophonia in your family, or do you experience it? It's a personal question. You don't have to answer it if you don't want to, but someone's
It's,
wondering.
it's
Oh,
no, it's I was trying to say it because we're seeing patients
mhm.
uh, who had a misophonia. And we were trying to help them and were unable to help them using approaches for hyperacusis. So it triggered thinking, and then we decided it's something new, not described in literature, not taken care by medical field, by anybody. So we need to name it, we need to define this, and we need to propose some treatment. And then world can just fight us and claim us that we're very stupid, which we might be, but start working to this. The worst part was that for 10 years or so, nobody was reacting to our observation of a paper, and only after 2012 or 11, misophonia gained some popularity and some this. So I believe that the crucial fact is that we are listening to the patient carefully and taking them very seriously and trying help them. And I think that this is so powerful in our family that our daughter, Anya Jastreboff, who is professor of endocrinology at Yale University and leading expert in obesity and obesity treatment with
And
the
who was just
drugs,
on Oprah recently, everybody. Not bad.
yes, and is publishing in January with Oprah book
Yes.
on her method, make a very strong point during first appearance in opera that a really very strong and that medical professional should listen and hear what patient is saying and take it very carefully into account. And this is my feature. This is a feature of Margaret. This is a feature of Anya. And this is allowing us to understand patient better and to develop new methods and new approaches to patient because we're not just we're thinking out of the box, but including what patient are telling us. And patient might have a totally incorrect opinion, doesn't matter, but facts are facts. And I strongly believe that if fact disagree with theory, it's very bad for theory, not for facts, but you need to listen carefully and have a sufficiently big group of patients. And as I told you, we have over 800 patients, which allow us to create idea about existence, misophonia, mechanism, and so on and so forth.
Thank you
And this
so
was
much.
described in this
Thank you
2000
so
paper.
much. Dr. Jastreboff, thank you again for this. This was illuminating, I'm sure, for everyone, and just a real honor to be able to hear your thoughts candidly and to learn from your whole career of experience. So thank you again on behalf of everyone here and on behalf of our team and everyone who will be hopefully watching and listening to this later on YouTube when it is posted. Just thank you. And we'll see everyone at our next webinar, which will be, when is our next webinar, Grace? Let's see. Our next webinar is going to be January 14th at 7 to 8 p.m. Eastern Time. I will be presenting my perspectives on top 10 advancements in misophonia from 2025. We do this every year. If you're curious about the last few years, you can go to our YouTube channel and you can see past presentations. So we look forward to seeing you all there, and we thank everybody for your time, and everybody take care and happy holidays.
Well, thank you very much for extremely kind words.